Hello, and welcome to the iMedx Best of Days series here at our annual hematology meeting in San Francisco. My name is Dr. Joseph McHale. I'm a hematologist at Mayo Clinic, and it's my pleasure today to welcome a very dear friend of mine, Dr. John Leonard, who is a world expert in lymphoproliferative diseases and lymphoma in particular, to join us for our session today. John, it's great to have you here.
Thanks. Nice to be here.
Excellent. I hope you're enjoying the meeting. You know, John, we have a lot of marvelous things happening in hematological malignancies, and one of the areas that we have seen quite a bit of growth over the last several years after a bit of a dearth there for a while was Hodgkin's disease, Hodgkin's lymphoma. I understand that there have been a lot of new data presented here, and I want us to talk through it a little bit. And why don't we start with upfront therapies? I know historically, I'm not the Hodgkin's expert, but ABVD has kind of been the standard for a long period of time. Has there been anything that's contributing to that here at the meeting?
So I think one of the themes about Hodgkin's, and I think for people in practice, is Hodgkin's is one of those malignancies where it's not that common. There are about 7,000 cases in the U.S. per year, but you don't want to mess it up, and that's why people at home in their practices who may not see that many cases just because of the frequency of it need to really stay on top of it because it is changing. The big thing in Hodgkin's over the last couple of years has been the availability of brentuximab vedotin, and so that's an anti-CD30 antibody. I'm sure people are becoming familiar with it, using it in their practice, conjugated to essentially a chemotherapy toxin, the vedotin part. And so this is a drug that's FDA approved for recurrent Hodgkin lymphoma and anaplastic large cell lymphoma, both of which are CD30 positive. And in the relapse setting, it's got somewhere between a 70 and 80% response rate, and progression-free survivals in a 7 to 9 month range. And so that is something that's very helpful for multiply relapsed Hodgkin's patients. Now what we're really learning is where do we use it earlier in the course of the disease. And so we've got a couple studies that I think give us a prelude to where that is going. They're not definitive yet. They're not randomized trials yet, or at least we don't have the results of the randomized trials. So the first of those is reported here by Joe Connors and colleagues. This is basically substituting brentuximab vedotin for bleomycin. You can't give bleomycin and brentuximab vedotin together. There's overlapping pulmonary toxicity, and so it's plugging in one B for another B. Okay. Or BVVD, depending on how you look at it. There are a number of ways of calling it. But the net is that there was a study that has been done in advanced stage Hodgkin's, and the results of this are that basically there's a 96% 3-year failure-free survival in patients with advanced Hodgkin's. So that's a great number. I mean, the historical data are upwards of 80% or so. So, you know, it looks good. It's a non-randomized trial. That has led to an ongoing international trial that's actively accruing that is randomizing patients with advanced stage Hodgkin's to standard ABVD for 6 cycles versus this regimen. And so, you know, it's interesting. Patients in my practice, we have this study open. Patients with Hodgkin's, you know, I offer them the study. It sounds good, but they say they go online, they meet patients with Hodgkin's who get ABVD who have done well, and they say, why do I need a new drug? But the fact that these numbers, at least in this initial study, are so good support the need for this study. So I think that's something that people should pay attention to. Certainly, if you have access to that study, it's worth keeping in mind.
And that same group, I understand, Joe Connors and his group have historically commented that the bleomycin may be not that critical to the ABVD regimen, so it may be a natural supplement.
It's been up and down. I mean, we had an alliance study where we left it out and substituted gemcitabine. The results weren't as great. Hard to know if that made a difference. You know, it's complicated, but I think certainly this is an interesting study, and I think these initial data support it. The other area where we've seen a lot of activity at this meeting and otherwise is saying, well, what about second-line patients? You know, brentuximab vedotin, it's an expensive drug, it's active, but you're still, because Hodgkin's patients do so well, you're still only getting an incremental benefit because it's you know, a minority of patients at best are the ones that are going to need it because they do well with ABVD. In the relapse setting, where we know as third-line therapy it's an effective single agent, what about the second-line kind of sweet spot? What about using it as part of second-line regimens? And so there have been a number of studies giving it alone, giving it with ice or as a prelude to ice or some other regimens to try to get the patients to transplant.
Okay.
As a single agent in second-line therapy, it only gets CRs it gets about 30-35% CRs, 30 to 35% PRs. So as a single agent second line, it's really, it's a minority of patients that are going to get teed up perfectly for transplant in a second CR. But we have data from Analycase and the Dana-Farber group being presented here, basically using brentuximab vedotin with bendamustine, which people are familiar with mostly in indolent lymphoma and mantle cell.
So you had another B.
Right. So
is this going to be the B and B
right.
studies, like the bed and breakfast study?
Or bread and breakfast. Anyway, I'll stop there. And the bottom line is that, so this is an outpatient regimen, which is great for patients. And at the end of the day, the overall response rates are somewhere in the 90% range.
Wow.
CR rates in the 80-ish% range. Again, small study, but the idea that you want the patient who's relapsed to get into a CR to be optimally set up for transplant. If you can do that at a high rate with this combination, it's outpatient. You have less, you don't have to admit the patient, perhaps a little bit less toxicity. I think that's an option for second-line therapy that might have some advantages over kind of standard treatment. So I found that interesting, and that may be a regimen I use a bit for my second-line Hodgkin's patients.
Okay, so we've talked a little bit about the possibility with time of using more brentuximab upfront. We've talked about using it earlier on, second-line therapy, and possibly with bendamustine.
Right.
How about after transplant? Right. There have been some work with brentuximab post-transplant.
Right. So the data that are out there with brentuximab post-transplant are its indications. So it's clearly an active drug there. However, it really it's a minority of CRs. They're durable in some patients, but at the end of the day, if you've relapsed after an auto transplant, brentuximab is usually only going to get you so far. So we still need other things. And the exciting thing here being presented at the meeting, which I think is really among the top, probably the top lymphoma abstract, relates to nivolumab, the immune checkpoint inhibitor. And so as the audience knows from solid tumor work, we have these immune checkpoint inhibitors. You have PD and PD-1, these sort of ways that T cells and tumor cells interact with each other. And the concept is that the tumor cells have these cloaking molecules on them that protect them from the immune system. And that by inhibiting those cloaking molecules, which this antibody does, at least one of them, you can reactivate the immune response and kill the tumor. So that's the concept. I think people are familiar with that by now in melanoma and other places where these drugs, lung cancer, where they're starting to get more attention. Hodgkin's is a great scenario for that, right? Because you look at the Hodgkin tumor and you have these Reed-Sternberg cells, which are a minority of the tumor cells scattered around, and then you have all these immune cells that are trying to get rid of the Reed-Sternberg cells and can't, presumably because the Reed-Sternberg cells are cloaked, exactly. And it turns out that these checkpoint inhibitory molecules or these immune checkpoint related molecules are part of the problem. And if you stain an assay for these, you see them there. So it really, not only are they interesting biologically, but it fits with what we know about the pathogenesis of Hodgkin's and how the immune protection is there. So in several studies, these are moving along. I think the study that's being presented here reported, and it's early days, but really dramatic response rates, somewhere in the range, I don't want to misquote it, but in the range of 50 patients, so a meaningful number of patients with response rates up around 80% or so at least in multiply relapsed Hodgkin's, including patients who have already progressed past brentuximab. And so that's getting a lot of attention from the regulatory authorities, and certainly one might envision that we're before long be replacing ABVD, which is a huge challenge of how you would ever do that given the track record of it. But when you get a couple of single agents like brentuximab and Nivo that can get you up single agents over 80%, it certainly calls into question, can we be backing down on the chemo and going differently?
So not quite ready for prime time yet, but this Nivo mechanism, this uncloaking or unmasking of the disease is something, as you mentioned, that we're familiar with in solid tumors, and actually has been presented here at the meeting in other heme malignancies as well, something to watch for. Well, let's move off Hodgkin's for a moment. I know that sounds like we've probably hit the top abstract in your world already, which is great. But let's talk a little bit for a moment about low-grade lymphomas. There are Of course, our audience would be very familiar with treating these patients. Right. With some of the enthusiasm around ibrutinib in different contexts,
right.
Anything about ibrutinib in follicular and the low-grade lymphomas?
Right. So as the audience knows, ibrutinib is approved for recurrent for CLL, recurrent CLL, as well as 17p deleted earlier, if I'm not mistaken, as well as relapsed mantle cell. And so the idea that the Bruton's tyrosine kinase inhibitor works in other B-cell malignancies, their data in large cell lymphoma subsets, other areas. There have
Even
been,
myeloma. We talked
exactly.
about myeloma in our Best of Day series.
So the reality is that everyone thinks, well, it should work in follicular lymphoma. Just about every drug in lymphoma works as well or better in follicular than it works in any other type. And so there have been a number of studies, and now that people have access to ibrutinib out in practice, they may be trying it in some patients, certainly. And the net is that we have a study led by Nancy Bartlett and her group, basically showing that in recurrent follicular lymphoma, the response rates to ibrutinib are about 30% or so. So, you know, not
a little bit disappointing than what you might have expected?
Disappointing, I would say. I mean, I think that a 30% drug these days in follicular lymphoma is pretty limited. Now, there had been prior studies, smaller numbers of patients, maybe a little higher, but I think in my mind, it calls into question some of the studies that we've been thinking of. Should we be combining ibrutinib here or not? It's important people know we do have idelalisib, the PI3 kinase delta inhibitor that's approved for recurrent follicular lymphoma, and the data with that agent are in double refractory, essentially chemo refractory and rituximab refractory follicular lymphoma are upwards of 50% with PFSs upwards of a year. So they've got an indication there. If you try to compare the apples and oranges, that looks to be a little bit better in follicular as opposed to ibrutinib. Now again, different studies, different populations, but so I would not be ready to jump on the ibrutinib bandwagon in follicular lymphoma, unlike mantle cell, and we'll get to that in a second, and CLL, where it's obviously changed things. Okay. The other big area in follicular lymphoma, or abstract in follicular, that really got my attention and I think is going to change my practice is not really a therapeutic one. We're looking for markers for follicular lymphoma patients. As the audience knows, you have patients that do poorly with follicular lymphoma. You have people that do very well. It's a very broad spectrum of disease. We don't have great biologic markers to sort it out. We have the International Prognostic Index, or IPI. We have the follicular IPI, which is a version of that. It's been fairly limited, and that's the challenge is you know, how do you pick the right treatment for individual patients, given that you have the range from watching and waiting to rituximab, to chemo-rituximab, to novel biologic agents, all of which it's kind of like it's turning into myeloma in some ways, where you can
you'll
mix
slowly
and match
catch up
things.
to us. That's okay. It'll take you a few more years, but you'll get
there. So the net is that the Mayo Clinic group had an abstract, and they have the Mayo and University of Iowa have a SPORE grant that has really been tremendous as a molecular epidemiology resource, a great database of patients with lots of information, and really has given us some good insights into a number of different areas in lymphoma. And so Matt Maurer, who's one of the statisticians in that group, basically looked at what he terms the EFS 12. So the idea of the patient population, you look at all comers with follicular lymphoma, how do the people who have an event within the 12 months of diagnosis. So an event can be I'm diagnosed and I get treatment, if I'm on watch and wait and I get treated, or I get initial treatment and I progress and have an event in the first 12 months versus those that don't and basically go longer than 12 months. And the net is that the EFS 12 people that have an event in the first 12 months do not do as well, not surprisingly. The other side of the coin, however, is that if you don't have an event, if you have follicular lymphoma and you don't have an event in the first 12 months from diagnosis, your survival is the same as age-matched control. So that's a tremendously powerful thing to say to a patient, to say, look, I know you're worried about follicular lymphoma. We've been watching and waiting, or we did some treatment, and it's a year later, and you're still good. Whatever we did or didn't do is still working. Nothing bad has happened. You're a year out. you are no different than your peers who don't have follicular lymphoma.
So that's a very sort of pragmatic, helpful, simple tool instead of the complexities of molecular and biological markers. Pragmatically, you go a year with nada, that's quite likely that you're going to do very well in the long term.
Now the problem is you want to know that marker day one, and we don't. So we like to say from day one, are you an EFS 12, this person or that person? On the flip side, and I think that's guiding a number of our studies in the next generation of our studies, that group that progresses within 12 months or has an event in 12 months, that's a group that's going to do poorly. And whatever we're doing for them right now doesn't work very well. And most of those in this database were treated with chemotherapy, but it really says that's a group we need to direct our studies to. That's a group where we're going to make the impact on.
But maybe even from the practicing clinician standpoint, they might be able to reassure patients a little bit more if they make it through that first year that there's a better outcome for them.
And I think anxiety for follicular lymphoma patients is a huge issue. That's something that, and quality of life in dealing with the disease, and being able to say that to somebody, I think is going to make a huge impact. So.
Well, let's turn our attention, maybe our last two topics, talk a little bit about diffuse large B-cell briefly, and then on to mantle cell before we wrap up. So from a diffuse large B-cell standpoint, you know, a lot of talk these days about double hit lymphomas. Anything from the double hit standpoint that we've learned?
So that's a challenging area of lymphoma. I think people are trying to, so it's basically a subset of large cell lymphoma that has abnormalities of MYC or abnormalities of BCL2 or both. And so the idea is that, and it can be by FISH, a MYC rearrangement, a BCL2 gene rearrangement, or immunohistochemistry. And so for the last year or two, the literature has been littered with is a MYC positive lymphoma, FISH positive for gene rearrangements, or immunohistochemistry positive, which is a larger group of patients because you can be FISH negative, IHC positive. Same thing with BCL2. And so the net of that is, and I think for people in practice, is that protein, more is bad, okay, regardless of how you've gotten it. So if you've got the protein without the FISH, you're still bad or less favorable, not necessarily bad. And so the question is, in highly proliferative, high IPI patients with high Ki-67s, aggressive disease, high LDHs, one should in practice be thinking about asking your pathologist to check for those markers, because those are patients who are not going to do as well. Now the question is, what do you do with those patients? And there are lots of retrospective series, some of which, there was one recently in the last year published in Blood, a retrospective analysis. And the question has been, do you give just R-CHOP like you treat the rest of the large cell lymphomas? Do you give something like hyper-CVAD or a Burkitt's type regimen? Aggressive. Or do you do something in between, the dose-adjusted R-EPOCH regimen? And so Kieran Dunleavy from the NCI and a multi-center group, including the cooperative groups, have a single-arm study looking at dose-adjusted R-EPOCH, which people are getting familiar with from large cell lymphoma, from mediastinal large cell lymphomas as well, basically looking at that in MYC positive. Now that being said, it's a prospective study, which is one of the first ones in this group, which is great. Admittedly, these are bad patients, so they're hard to get on studies because they're really sick, so you wonder if there's some selection there, but nonetheless, you know, this is how you have to do it. And the net is that with about a year and a half of follow-up, roughly the PFS is about 60–70%. So compared to historical data, which run around 30%, that looks good. It's short follow-up. There are lots of caveats, obviously no comparison. But these patients tend to progress early, so you know that follow-up is not horrible for this group because you would expect to see many of the events early in this histology. And so I think that that's a reasonable way to treat this patient population. Probably not going to solve the problem. The questions of, do you transplant them, do you do something else? It's interesting. They either do very poorly early, or if you get them into remission, they may not do quite so badly. It's just getting them into remission is the challenge. And we'll see more data on that. I think that's going to be a building block then to develop new drugs on top of that, and it's probably a reasonable prospective benchmark to take forward. Okay.
Well, just before we leave large cell, any new compounds, novel areas for large cell lymphomas? We've been hearing a little bit about these nuclear transport agents.
Right. So one drug I think that I found to be the most interesting. I mean, there are lots of drugs in recurrent large cell lymphoma that have been through the mill, so to speak, with kind of 25–30% response rates, short responses. One of the drugs in our group happens to be working with it, but it's an abstract, and I believe it's also being studied in other malignancies like myeloma. It's a drug called selinexor. It's a selective, or SINE inhibitor, selective inhibitor of nuclear export. So the idea is that the trafficking of molecules in and out of the nucleus gets blocked. They can't traffic. The nucleus and the cell gets unhappy. That has a number of different effects on proliferation. And so this is a drug, selinexor, that in phase 1 trials, there are a number of different dosing and schedules that have been looked at, so it's hard to know where the dust is going to settle. But it's had somewhere in the range of about 40% response rate in recurrent large cell lymphoma. This is a bad group of patients. And the interesting thing is that some of them are durable, and they're seeing complete remissions. And to see complete remissions with a single agent in the relapse setting is of interest. So it's early days, but I think that we've been struggling to find new drugs for large cell lymphoma since rituximab. There's really not been a whole lot new that's had a major impact so far. And this is one that I think is coming along. And there are also data looking at it in Richter's transformation and a few other scenarios. So
not quite ready for prime time yet.
Yeah, but something to pay attention to. Yeah.
Well, before we close, let's take one more abstract. Let's switch our attention to mantle cell lymphoma. And I understand part of the work that you've been working on and presenting is looking at almost can I call it a chemo-free regimen in mantle cell. Mantle cell still remains a challenging disorder to control, but tell us a little bit about some of the work that's being presented here in mantle cell.
Yeah, it's interesting. I just came from the oral session where we had a number of different upfront cooperative group and other studies looking at intensive regimens. We saw the European Mantle Cell Consortium presented their kind of backbone of R-CHOP followed by DHAP followed by autotransplant. They had an abstract adding maintenance or not, looking at that. We had SWOG presented data on R-CHOP with bortezomib added in and as a maintenance. And looking at those, and then there was another European study looking at bendamustine, bortezomib, rituximab. And all of those really, you start to see a substantial number of patients progress 2 to 3 years after. And so I think that it's been a little bit frustrating in trying to take that forward. And the questions remain with new drugs, what combinations, do we need a transplant? So our group has really approached mantle cell almost as follicular lymphoma. And we said, look, you don't really need a transplant. If it doesn't cure you and you don't live longer, it's a quality of life decision, basically. And so much as what's happened in myeloma, we're starting to get to the point of questioning transplant, I think. And so we had a study of lenalidomide, rituximab, Giaruan in our group developed, which is really the first regimen to treat patients with a chemo-free regimen upfront for mantle cell. And we treated about 38 patients, this was a small multi-center group, 38 patients, median age 65, so a very typical group for mantle cell as opposed to the transplant regimen studies. And basically about 88% of patients went into remission, and our 2-year PFS is somewhere around 80%. So it's early.
Pretty impressive for that kind of regimen, as it were.
Yeah. Exactly. So, it's early, but I think it's the sort of thing that, whether or not, the big question is, are you better? And I'm sure you face this in myeloma, although the data for maintenance in myeloma after transplant obviously is a little bit different. But, do you do an intensive regimen up front and then watch? Or do you stay on chronic therapy for years and years? Which are you better off? And if the results are the same, is the patient's quality of life better getting it over with or staying on, say, lenalidomide or some other maintenance regimen chronically over time? Those are the questions.
So still early to know, but maybe I'd think of sort of older patients or patients whom a more intensive strategy wouldn't be ideal for them, that this may be something that can be considered. Well, thanks, John. It's always great to have you. I appreciate you very much being here, and thank you for joining us today for our Best of Day series here at our annual hematology meeting. We trust that you've learned a little bit more about lymphoma today, both Hodgkin's and non-Hodgkin's lymphoma, and we look forward to seeing you at one of our future events. Thank you for your attention.